Can probably go ahead and get started. I'm sure there'll be some people that come in a little bit late, which is okay. Welcome to the fifth and final session. You've made it to the end. Congratulations on taking the time for 5 consecutive Saturdays to dedicate to your prep. Today's session will be health technology and information management. That's going to be roughly 16 questions on the test. Um, and you don't have to be a healthcare IT expert for it. It's going to be a lot of the stuff you deal with probably on a regular basis. So we'll go through some of those questions, kind of see what the makeup of them is. And then we'll do some closing comments, some recommendations on how to prep moving forward, and answer any final questions you have. Go ahead and go to the next slide. And of course, today I am here, Ryan DeGive. We have Rick as well as Grace. And unfortunately, our SOHL counterparts has got a first cold of the year, unfortunately. So Mary will not be with us, but appreciate all our help this year. Just a couple quick updates and then we'll get started. So SurveyMonkey will be released by our CAHL admin. Keep an eye out for that. It should be coming this coming week. We encourage you to go ahead and fill that out. We appreciate your feedback. We definitely use it to help improve further our future sessions. Again, you get 8 qualifying education units. These are self-reportable. I usually recommend just doing one event with a start date for the first date of the session that we started on, and then an end date. You would put today's date, just put the 8 CE units, and just put that it was the Cal Sol Board of Governors series. ACHE knows our program pretty well by now. They know that we conduct it in accordance. So, um, oh, never mind, 525. I don't know why that got on there. But yeah, go ahead and put those into your own My ACHE profile. If you have trouble doing that, let me know. Feel free to reach out. I can send you a guide on how to put that in there. Um, there will be no session 525. I don't know why that's still on there. That was a typo. But definitely there will not be a 525 session this fall quarter. So I will be your presenter today for all the questions. Again, my name is Ryan DeGive. I've been your MC this whole time. It's finally me in the spotlight, so looking forward to going over some of the health IT questions with you. I currently work for Contra Costa Public Health Department. I spent about 15 years in the hospital side, working in patient flow operations, dealing a lot with IT, with data. Along the way, I was briefly an Epic analyst. I am certified in Grand Central and Prelude, so I have some behind the scenes experience with IT. And I've also served as a functional tech on various systems. So I am familiar with IT from multiple angles, but I've never been fully trained as a analyst, I guess you would say. Well, I was trained as an analyst, but I never took any formal education. But I feel like I can kind of speak to this. So, like everyone else, I won't really go through all of the things you need to know. We did send this out ahead of time, but just basically what IT is, how it fits into business operations, different trends that you see in healthcare, especially I know you probably heard AI floating around a lot, just understanding the different things that are going on within healthcare IT, the acts like the High Tech Act, meaningful use, the switching from paper-based systems to electronic healthcare systems, that sort of thing. And of course, data support, different equipment, interoperability is a big word that you probably hear, just the ability to utilize different systems together. We can go to the next slide. Doesn't need this. So yeah, definitely IT systems within healthcare. It's not just about the health record, although that's a main part of it. You also see financial systems within healthcare to track payments, You see clinical decision support to kind of help with the overall operations of things that go on. You also see basic IT like every other industry has, printer, computer, network, all of that. Disaster planning is also a big thing. We're so reliant now on IT and on the internet and a network that if something goes down, you want to be able to um, get up and running as quickly as possible and have a backup plan for what you're going to do, especially if you're working in a clinic or a hospital that is regularly seeing patients and can't shut down. There's also security, making sure that you keep protected health information safe. Um, yeah, and healthcare analytics, that's another big one. So we want to see what trends are going on within healthcare. We want to see what volumes we have to see where if we need to get into a new market, we need to improve a specific service line. And we also want to see outcomes data, like what are we doing right to help our patients? Where can we improve? And also, especially with clinical trials, what's working right and how are we utilizing new technology to and drugs to, save lives. We'll give it a second and then we can go on to the next slide. Looks like the computer's thinking. Grace's Zoom just froze, I think.
Ryan, hold on just a second. Let me see. Second.
Well, this is the IT session, so it's a perfect time to have an IT issue. Very fitting. Bear with us 1 second. We'll figure it out.
You're seeing mine now?
Yes.
Okay, I think we're good. Ready for the questions?
Yeah, let's go for it. Okay, so like we've been doing, I'll read the question. I'll go ahead and look over the answers, read out the answers as well. Uh-oh, I didn't see it. Um, please feel free to put your thoughts in the chat. We'll be monitoring that as well. You can play along with me and um, take a take a stab at these questions as well. So, question number one. A CMS program that requires provider to consult a qualified clinical decision support mechanism for the appropriateness of a diagnostic imaging service is called. So what they're looking for with this is we're looking at what system a provider would use to kind of verify that the test that they're ordering is appropriate, either for reimbursement purposes, which sometimes have to happen in order to get the test pushed through insurance, or just to make sure that they're ordering the right test for the patient. Um, so let's go through the answers. A, Health Information Technology for Economic and Clinical Health Act. So that seems more like what am I looking for? It's not necessarily a clinical decision support system. That is more of a government regulation or um, something within the federal government that's requiring how things are utilized with health information technology. Protecting Access to Medicare Act of 2014. I'm not sure what that is. 2014 seems like a weird year that they would do a Medicare Act. Meaningful use. Well, meaningful use is the way that you utilize technology. It's a term that gets used a lot for making sure that we're properly adhering to guidelines while also using the systems for what they're meant for. American Recovery and Reinvestment Act of 2009. So I remember that act. I don't remember what exactly was in it though. I know C for sure is not correct. A doesn't sound like because of the economic, it could be because we're looking at the appropriateness, whether it's something that would be financially viable. So Protecting Access to Medicare Act of 2014. I don't think C or D, because I don't remember D really having anything to do with support mechanisms. High-Tech Information Technology for Economic Clinical Health Act. So what catches my eye with B when I'm reading through it is the Medicare Act. And when I was initially reading through the question, thinking about, okay, why would they have to consult a clinical decision support mechanism? My thought was, okay, with Medicare, you oftentimes have to draft an ABN, trying to make sure that you're um, ordering something that's both necessary and reimbursable. So I feel like B is the answer I want to go with. What's the chat say? D and C.
Yeah, one B, one C.
Oh, B and C, yeah. I think I'm going to go with B. It
And
is
B is
B.
correct.
I'm not sure what Rick, do you know what that act, the Medicare Act of 2014 was?
I have absolutely no idea. And um, so I'm trying to think back of what else was going on. That was right after Affordable Care Act was implemented, but I don't remember a specific act about Medicare. Ready for the next one?
Yeah, let's go on to number two. The COVID-19 pandemic played a significant role in the expansion of telehealth with the 1135 waiver by 1135 waiver, allowing Medicare beneficiaries to receive services in a designated rural area. Well, they should have been receiving services already in rural areas. So I don't think that would have changed with COVID. Allowing Medicare beneficiaries to receive services at clinics, hospitals, and certain types of medical facilities. Again, that should have been something for the most part that was already occurring before COVID. Encouraging a non-face-to-face communication through online portal services. That does sound, that was something that did occur after COVID hit. It was more um, non-face-to-face communication, being able to email your provider easier, contact them without having to come in. Um, what's D though? Medicare paying for office, hospital, and other visits through telehealth across the country, including patient's place of residence. So that was what telehealth really was, especially after the pandemic, was you were able to do office visits, certain hospital visits through um, your computer, through your phone while at home. So that makes sense. So me, A and B definitely I can cross off, just torn between C and D at the moment. So there was an encouragement to communicate, but communicate, people were able to communicate online even before COVID. I'm not sure what they mean by portal services, because I know there was a big push 3, 4 years before COVID to be able to contact your doctor virtually, at least ask questions. So I'm not sure the communication piece really took off because of COVID. So I think D makes the most sense because pandemic, that's when telehealth really geared up, and that's what D is really talking about. What about the chat? Yeah, looks like everyone's saying D. I'm gonna go with D.
And it's D.
It's D. Do you know what the the 1135 waiver is?
Yeah, 1135, that one I do know. 1135 is the provision that CMS, Center for Medicare and Medicaid, can waive specific rules. And, up till this point, pre-COVID, uh, telehealth was, which allowed telehealth to take off.
Makes sense.
There were a bunch of other 1135 waivers. It was just a lot of stuff got waived that year. It was a great year. Next one.
Yeah, let's go into number three. Why is it important for the IT strategy to align with the organization's goals and objectives? So basically, why do you want to make sure that IT is aligning with operations? To increase Medicare payments, possibly, but it doesn't guarantee that you're going to get more money from Medicare. To improve access to data for management providers and consumers, it could help depending upon the technology and if that's, one of your goals is to increase the access to data, having the right IT plan can help with that. But let's go on to C, to allow the CEO to control IT spending. I don't know how much the CEO controls IT spending. Um, yeah, I think C I can cross off pretty easily. D, to give the CIO a seat on the executive committee. Well, I don't know why that would automatically put them on the executive committee of a board just because they're aligning strategy. That should be part of their overall job role and not necessarily grant them access to being on the executive committee. So I don't really think D fits. Um, and I don't really think A, you're not necessarily going to increase Medicare payments. Um, so B is the one I'm leaning towards. And, aligning IT strategy would definitely improve that if that's something that you're trying to do. Yeah, and it looks like we got consensus in the chat as well. Let's go with B, and it's B.
Ryan, the other thing that kind of struck me with the four choices is that three of them were very specific things. So right or wrong, like allowing the CO to control spending, they're all really general, or to be real specific, where B is a much broader general purpose for IT strategy. What are you
Yeah,
trying to push with your strategy?
that's a great point.
It stood apart from the other three in that sense.
Yeah, and it made more sense. Like it's something that would be produced when you're aligning those.
Number four.
Number four. What competencies do not matter in selecting a CIO? Sounds like a human resource question. Um, A, prior management experience. Anyone in the C-suite you're going to want to have prior management experience for, so that one's an automatic false. Knowledge of healthcare organization and delivery. Well, you're going to want a CIO, even if they're more IT focused and have a stronger IT background to understand healthcare to some extent. Um, So I think that one I'll leave just for the moment till I read the other ones. Personal relationship with a board member. That definitely does not matter. Um, I would think having a personal relationship with a board member would automatically be not necessarily a conflict of interest, but um, isn't necessarily something that every person who's in a higher level would necessarily need to have. They might have a personal relationship just to help get their foot in the door, or be somebody that's on a list of possible candidates, but it shouldn't matter when selecting the CIO if they have that relationship. Um, finance and budgeting skills. And again, somebody in management, you're going to want to have at least some skills with a budget. So I think A and D both are definitely something you'd want. So I would take those off as false. That leaves me with B and C. I don't really think a personal relationship with a board member is necessary when selecting. It might be helpful, but it's not something that matters. People get sourced from all over the country to come the different roles, and they may not know anyone with the organization they're joining. So I don't really think C is something that matters. I do think um, B is something that does matter. You do want somebody who has general idea of healthcare. Even if they have more tech experience, they need to understand how hospitals and clinics and insurance companies and everything run. So I think I can easily eliminate B. That's something you'd want. So I think C is something that doesn't matter. Looks like the chat agrees with me. Let's go with C. So this is kind of one of those ones where you have to select everything
In the
that,
question carefully.
sorry, what, Rick?
I would say it's just a reminder to make sure you read the question carefully and
Yeah.
make sure you're picking up the not.
Yeah, that's the key word right there is not. So you, you can look for what is so you can rule them out. You know that management experience is important when you're hiring somebody in a high level. You know that having healthcare experience is important, and you know that finance and budgeting skills are usually within the job description of somebody in a leadership role. So that can kind of help weed those three out. All right, let's go on to five. When introducing a new information technology system to a healthcare organization, resistance can be effectively addressed by. So this kind of goes to the topic that Navi covered with quality management and going through and improving things. You're introducing a new healthcare technology system, um, similar to if you're introducing a new process or workflow, you're always going to get resistance. So what are the ways to kind of get through that? A, eliminating existing social groups that appear within an organization. I don't think that's an easy thing to do. There's always going to be social groups in any organization, um, for different reasons. So I don't think that's something that will really impact the ability to successfully introduce a new system. Employing a policy of mandated use throughout the organization. Um, you may need to mandate that this is the way it's going to be, but usually you don't want to do that to try and address initial resistance. That's usually a last effort that this is the way it is. You have to do it. So I wouldn't say that can effectively address something that's more of a um, ultimate authority move. C, focusing on the system users and being responsive to their needs. So that's, definitely when you're rolling things out, especially if you have a team, you're introducing a new concept. Um, you want to sit there and be responsive to what their thoughts are, have them involved, make sure that they're feeling supported throughout it all. That way they're going to be more successful. So C really stands out to me, but let's look at D. Rapidly introducing the system changes to allow the staff to see the cost savings. Yeah, nothing like rushing things through to make things better. With that one, rapidly, normally you don't want to rapidly introduce something, especially an information technology system that's going to impact the way people are doing things. You want to make sure they're trained and ready to go. Um, and staff aren't usually, depending upon which level they are in the organization, even some, leaders aren't always necessarily interested in what the cost savings is going to be. That's not what their focus is. So I think D can be removed. A definitely can be removed. You're not gonna address social groups. And I think B, like I said, is just one of those things that you develop a policy and you say that you have to do it this way. That's not gonna stop the resistance. It's gonna probably cause additional problems. And I think C, when I think back to my experience in different projects that I've been on in different roles, whenever you get the system users involved and, make sure they're comfortable with things, that always seems to help with whatever the project is, introducing the changes. Um, so I think I want to go with C. Yeah, and it looks like I have consensus in the chat. Let's go with C.
This one also touches on change theory generally, and are you trying to change attitudes or change behaviors? B might change the behavior, but the resistance is still going to be there, the attitude. So,
Yeah. If
okay,
anything, you're gonna cause more resistance when you start
exactly.
mandating things and say, do as I say. It's not gonna help the situation.
No, for sure.
All right. Number six, the best way to facilitate information system integration within a healthcare organization is to, so integration, um, trying to get everything together to talk basically. So A, centralize all computer activities. I don't know what you would be centralizing in terms of the activities or what activities they're looking at. B, use computer equipment from only one manufacturer. Um, that doesn't normally happen no matter where you are, especially if you need a new keyboard or a mouse. It's not going to match your monitor or your laptop, so equipment from one manufacturer isn't going to impact integration. Use computer software from only one vendor. Um, there are certain vendors out there that would like to see that happen, but for the most part, you're going to have different software depending upon what you're doing. That also works with different equipment as well, so I don't see that helping with integration. So standardized data definitions and data structures. So when I think integration, I think about talking between systems, being able to send data from one system to another system. And the main component in that is trying to standardize what the data definitions are and how they're built out as best as possible so that the systems talk, so the data isn't lost when it goes from one system to another. So to me, that's kind of a standard of integration. Um, I'm not really sure what they mean by centralized computer activities, so I'm leaning towards ruling that out. I can easily rule out B and C just because you're not going to, currently, we don't have just one vendor that can offer everything. Um, so those two I can rule out. And I like the fact that D is almost like a definition of it. Um, looks like the chat agrees with me. Yeah, let's go D. I think that keyword's integration. If you kind of know what that's leaning towards, it spells it out right there in D.
With A, I was thinking back to like the 1970s, 1980s, before we had personal computers on our desks, and we did have just a big central computer for everything.
That that's what I was trying to figure out too. Do they mean like a centralized computer
Yeah, something like that.
warehouse type thing?
Yeah.
Number seven, knowledge management is defined as A, the practice of explicitly and deliberately building, renewing, and applying relevant intellectual assets to maximize organizational effectiveness. So when I think of knowledge management, I think of a repository, and A makes me think of a repository. You're kind of building your library of um, best practice of data, of different assets. So I like A, but let me look at the other answers just to make sure. The transfer of structured information between two computer systems. Well, luckily we just answered a question that talked about that, the integration. Um, so B, I'm gonna cross out. That's not knowledge management. A movement to explicitly use the current best available scientific evidence for managerial decision making. So that to me sounds like evidence-based practices or clinical decision support, which builds off of knowledge management but isn't knowledge management. D, the planning, organizing, directing, and controlling of resources to accomplish goals and objectives related to a distinct initiative. That sounds more like a definition of operations or of, projects, rolling things out, carrying on business as usual. I wouldn't say that's knowledge management. The practice of explicitly and deliberately building, renewing, and applying relevant intellectual assets to maximize organizational effectiveness. So with knowledge management, you have a repository that you can draw from that you're constantly building and adding to, all with the goal of, improving the organization. So when I read A, even if I don't fully know the definition of knowledge management, it sounds, what a knowledge repository would be to me. Let's see the chat. Looks like we have some A and D.
I think D was from the last one. I think
Oh,
there,
is it from the last one? Okay. Looks like we have a couple A's, so I feel comfortable with A. That was kind of my initial thought when I read it, that it defines what, a knowledge management, if I think of even just my own knowledge repository that I use, um, to me that would be a definition of that in some ways. So I like A. Let's go with A. Cool. No questions in the chat? No. All right. 8. Which of the following is a reason that system support of outcomes data collection and analysis can be very complex? So gathering data and analyzing it, complex. The required data typically resides in multiple informational systems and in manual processes. That is true. In most places, like we said, there's not one system that does everything per se. So you're going to have data from different systems you're going to have to pull, and there are still manual processes that people use in tracking, or even the type of data you're looking for. You might be looking for um, personal experience in that. Um, so that could be a good answer to that, but let's go on. The functional departments are not integrated with the financial informational system. I'm not really sure what that would have to do with this. Plus, depending upon what the department is, they wouldn't necessarily need to be tied in with. an informational system. I don't know how that would impact outcomes per se. There's inconsistent medical terminology across different clinical systems. There could be, but like we mentioned in one of the earlier questions with integration, trying to standardize everything, if you're running efficiently, you wouldn't have that issue. Variation exists between open system architecture, interface engines, and multimedia data entry options. So I think that kind of ties in with C in my opinion, because the interface engine's trying to, integrate what's in one system to another. You'd want common terminology. Um, so I mean, if you have all those issues, that would already be complex, but I think they're talking about even in a well-supported system, you have a system support in place. Why is it still complex? So I think C and D I can rule out. I do know that A, there is true parts of that. It does reside in multiple informational systems, like we mentioned. There's um, systems that have to talk to each other. Um, and sometimes you have to pull data out of the different systems. You can't just pull it out of one single one. Um, there's still qualitative data that you may need that are in manual systems that are directly from people. That can add to the complexity trying to tie all that together. I think A is the most likely one for this one. Um, Dan, it looks like there's consistency in the chat. That's A. I think it's the complexity when you look at that. You're looking at pulling data from different systems, trying to make sense of it, trying to make sense of the qualitative data you may find when you talk with people, and then putting that all together into a something to display to upper leadership or to the public. Um, I think that qualitative manual systems type data can also just be the way that it's entered and the way that it's interpreted um, by the people doing the work sometimes as well.
Ryan, I have a question for you.
Yeah,
When I read the question, I focused on outcomes data specifically. And now I'm wondering, does that make it easier to answer when you narrow it down to just one type of data collection, or are the answers really more universal for all data collection?
I think that's a good point. I didn't focus on that outcomes data, but if you do focus, even if you're looking at one type of data, um, it can make it easier, I think, if you know more about the outcomes data. I think to me, just having pulled different data for different things, I kind of relied on that when I was looking at it. I didn't think of it from a more general perspective. I think that's a good point. You could, when you're looking at a specific type of data, knowing that it's in different systems, there might be different um, things you're pulling out and trying to make sense of for outcomes data. That might help with the question as well. All right, number 9. Membership of the IT steering committee should be comprised of, so basically the IT steering committee, you're going to have people that are helping with understanding projects that um, need to be prioritized, or new projects that need to be taken on, or updates to existing um, infrastructure. So it's just a group of people that are trying to help decide what needs to be worked on and the impacts of it all. So A, the CEO, the CIO, the CFO, the chief of medical staff, and the chair of the governing board. IT steering committee wouldn't normally have somebody from the board, I would say, unless that person's also a staff member at the organization. So just seeing that kind of makes me turn away from A, and I don't necessarily think the CFO or the CEO is always on the IT steering committee unless maybe it's a smaller organization and they want to be more hands-on. That's normally something you would see a CIO solely at, maybe a chief of medical staff if it's something that you're that's going to impact patient care. Um, Representatives of administration, physician leadership, information systems management, and major use departments. So I like this because it's not necessarily specific for who needs to be on it, and it seems to capture the majority of the stakeholders who would be involved in a lot of these projects or impacted by a lot of these projects. So I do like B. The CIO and senior systems analysts. So the only problem with only having IT and an IT steering committee is you don't have input from other areas. And the design of a steering committee is usually to have input from various people who would be impacted. So I think only having IT there would not be useful. So I don't think C is a valid answer. The CIO and outside technical consultants. So again, along with C, I don't think D would be something that you would have, especially if it's an outside technical consultant. They wouldn't necessarily be involved with other things within the organization and would be more likely to be able to speak to what could be done versus what needs to be looked at. So I don't see that being them being part of the membership. And again, if I look at A, that just seems a little top heavy, and then having somebody from the governing board who wouldn't be involved in a lot of the operational workflows necessarily. I like B because it kind of includes, what a steering committee, regardless of what it's for, would normally be. You'd have multiple departments involved trying to come together to see what direction to go into. So I'm gonna go with B. And it looks like chat's going with B, so let's go with B.
Seemed
All
like a
right.
couple of weeks ago we had a question that was also about who should be involved in some activity. And the answer was similar in that it was, well, who's really involved? Put them on the steering committee. So that might just be a general thing to look at anytime you get a question of, who should be on a question, who should be on a committee or something.
Yeah, and I think especially with that answer, like I said, it's broad, but it captures multiple points of view, which is what you normally would want on a steering committee of any kind, people who are impacted and um, having them involved. So 10, selection of an information system in a healthcare organization should begin with, um, so when I see that word should begin with, I'm wondering if the answers I see are going to be all valid, but I'm looking for the one that should be the first step. So A, meeting with several information systems vendors to determine the scope of available technology. So when you're selecting an informational system, that should be something you do. I don't know that that would necessarily be the first step, though. B, hiring an information system consultant to determine the organization's strategic needs. Hmm. C, development of an information systems plan that supports the organization's existing strategic objectives. That kind of sounds like that question we had earlier about aligning the strategy with the operation strategy. So I like how that tied in. But let's see, D, evaluation of available hardware and software to best determine what meets the organization's needs. Hmm. Well, so I know A definitely would not be the first step because usually if you're looking at available technology, you've already determined what you're trying to find. So I think A would not be the first step. So you wouldn't begin there. Um, B, I don't necessarily know that you would want a consultant to tell you what your strategic needs are. Um, I know there's cases where you may hire outside consultants to do a lot of improvement work to help flush stuff out, but I don't think that would be your first step when you're trying to get an information system. Um, Although it might be, you might be starting from scratch and want somebody who has experience. But again, I don't know if the consultant would be the ultimate one that would be determining that. That would be something that would be, again, like an IT steering committee or members of leadership in different departments figuring out what the strategic needs are. I like C because again, it goes back to that other question that we had where it aligns what your informational systems plan is with the organizational strategic objectives. Because if your organization's going a certain way, you're going to want to make sure that if you're implementing an IT system, it aligns with what those objectives are. So I feel like that would be a starting point, a beginning to your first step when selecting an information system. So you would be looking for a specific information system that helps you align, evaluating available hardware and software. So again, D is one that you kind of do after you've already established what it is you're looking for. So A and D, I can cross off. Those would be later on in the process. I feel like part of a plan might be to hire a consultant. So if I'm looking at B, B might be a second or third step in the process. It wouldn't be the first because that wouldn't be the automatic go-to you have. You would have objectives you want to meet and you're trying to develop your IT system to align with those. So part of that might include in a future step hiring a consultant to better look at what your strategic needs are system-wise. See, I think C makes the most sense because that's what um, you're trying to align it with your strategic objectives again. So that would be your first step in the process when you're going to select an informational system. You want something that is going to help you achieve your operational objectives. Looks like the chat agrees with me, so let's go with C. So it's one of those questions that you read and it says begin. So they're going to be true answers in there. You just have to kind of figure out how to put them in order to find out what should be the first one. All right. In the IT system development lifecycle, which is the most important step? So it's kind of like a project life cycle. When I read that, it makes me think of that. Um, so A, system analysis. B, system design, C, system acquisition, D, implementation. So design is important. I don't know that acquisition is the most important step. It's just a step in order to move forward if you're purchasing a IT system. Implementing the system is definitely important, but there's a lot that goes on before that which impacts implementation. If you do things correctly, the planning and everything, it helps when you go to implement. It's like with any project. So I don't think C and D. Analyzing. So if you're analyzing the current system or the current way things are done, that helps you with the next steps of design and planning. But is it the most important part? So I'm stuck between A and B just because I think they're both important steps. You want to make sure you have all your pre-planning and analysis done, and then when you're designing and planning how things will carry out, those are both going to be essential. I'm leaning more towards A just because if you have everything done correctly at that step, it helps to make sure that when you're designing the system, everything runs smoothly. It's like with any project, if you have all your facts straight ahead of time before you start, designing an approach to change, um, that you're more successful. So I would think A is probably the most important step, like analyzing the current state and understanding um, where you're at. Um, Implementation is the last step, but sometimes we may need to change the design. That's a great point. And let's see. Yeah, I think let's go with A.
Ryan, isn't this the same question as the previous one where it said we're going to start with the plan? And to me, the analysis is analyzing what exists, what our needs are to figure out what we should design, then acquire, then implement.
I agree. I think that's what kind of struck me was that's you have to understand what your current state is and what your um where you're at in order to kind of plan and design to move forward. So I would think that would be essential if we're looking at it in a broad term. You know, if you have step A done correctly, it's only going to help you with step B, step C, step D. Um, so that's where my mind kind of went was you're going to be more successful with the others if you've done everything correctly with that, beginning step, like we said in that previous question. So yeah, I agree. Number 12, an application that accesses structured databases of clinical information to aid a clinical provider in defining probable diagnosis or selecting appropriate diagnostic tests or treatment options. I think we probably should have had an is after that. Um, so that makes me think of a decision support system, but let's see. A data warehouse. So a data warehouse is where you would access structured databases from. Um, so that's not the application. B, clinical decision support system. So there's decision support, like I was thinking. Um, so that would be a system that would help you access that data warehouse. C, health informatics. It's a very broad term. Can mean a lot of different things, and it's not an application. Um, so I think C, I can easily. Weed out D, clinical data repository. So that one could be like a data warehouse, or it could be a data system you access. But again, that's a system, it's not an actual application, which is why I was originally thinking decision support system. That would be an application you would utilize to um, pull data from either a repository or a warehouse. So I think B is the most likely answer. It looks like consensus in the chat, and it's B. Yeah, I think the keyword there is application. Because I mean, structured databases of clinical information, you're going to find those in data warehouses. You're going to find them in data repositories. You'll even find them in health informational systems, if that's what C is kind of alluding to. Um, but it's the application you're utilizing to pull that data. Um, and when you're trying to use it as a provider to select something or look at different treatment options, it's, decision support. It's helping you support the decision you're leaning towards. So I think that stuck out to me automatically as a decision support, and then B has that right in it. So, um, but then again, I wanted to make sure I went through every single answer to not just jump to it because I thought decision support off the top of my head.
We spoke earlier in the program about the importance of making sure you're really clear on what it is the question's asking for and how it's particularly important when you have a question with a lot of words in it like this one. So when I was trying to go through this one, I ended up breaking it into three parts. So an application that accesses structured databases was one, to aid a clinical provider was two, and then three was in defining probable diagnosis. So my focus then went to the second one because I could eliminate the third. It doesn't matter. It's an application to aid a clinical provider in defining something. Okay. It doesn't matter what. So said what here aids a clinical provider? And then C is the answer then, decision support, changing how you make decisions.
And I think that's a great point to make because you came about that from a different angle than I was focusing on that first part where it was an application. So I'm thinking, okay, what's a system or a program you would use to do that? But you can also come to the same answer from breaking it down, looking at it a different perspective if you're not thinking um, like IT wise of, oh, you need this program you need SQL to be attached to whatever to pull data type thing. Um,
You're going to look at it differently being an IT guy than I am.
exactly.
Uh, and it doesn't matter. I mean,
Hmm.
no matter, this is an area that a lot of people are not going to be the strongest at, but you can break it down. You look at the question really specifically, don't speed through it, and say, what is it that they're trying to find? And break it down until you can find a words or group of words that helps you pick which of the choices you want to get rid of and leave the one you want.
Yeah, and I think this is a great example of that, how you can look at it from multiple perspectives and still end up at the same answer. So, as Rick's saying, you don't have to be familiar with IT as much to still be able to understand what they're asking and find the best answer. Oh, that was it.
I have two questions for you. Um, One is none of our sample questions here got into hardware. And earlier, I know that some of the test questions or study questions or recommendations did get into different computer configurations. Have they eliminated those, or is it just not as important, or what's your thought?
I'm trying to think back when I took the test, what IT questions I ran across. Um, I think it's still important to have a basic understanding. Um,
Is there a
but
good course you would recommend for people who don't know computer hardware or computer networking that
There's
would.
actually the book um, that ACHE has in the study bundle. It's Healthcare IT. Um, I skimmed through a lot of that just to look at it, but I think, looking at that will give you those breakdowns, not only like of the questions that we had here, just the general stuff, but also more of the components and hardware and everything like you were talking about the general IT portion of it is covered in there if I remember correctly. So I think that would be a good guide to look through is um, an IT book. There's also what's it called? Hymns Society as well. If you go to their website, they have uh, a lot of free articles and different things you can draw from to kind of brush up on the latest IT and different different components of the healthcare IT universe if you want to dig a little bit deeper into there. But I think that the actual textbook would be helpful, especially if you're just trying to brush up on some of the basic IT components and terms like integration, interface, IT systems, what clinical decision support systems are, that type of thing.
So it's back to, doing your self-assessment of what areas are you strong in already and where do you want to focus your studying. And if you're like me and know nothing about the hardware, it'd probably be worth taking a look at that book.
Yeah,
So my second question is, in the last few years, obviously cybersecurity has been a major issue for hospitals and getting attacked, having our IT systems totally shut down. Um, ACHE tends to run a couple of years behind the world on its questions because they write new questions and they test them out for a year with people, those extra 30 questions. They test them out to see if they really are getting the right answers. So I'm thinking that around now we can probably start anticipating getting some cybersecurity questions.
that's a great point. I think, especially as that's become more of a focus within organizations of having that, having everything run through a cybersecurity team to make sure that this outside vendor that you're going to partner with and developing this new system isn't somebody who's going to just open up the world to your data. I think is an important piece, and I think I'll have to look. I'll look through the past offerings that ACHE has had, but I think they've done a couple. I don't know if it's interviews or um, podcasts or whatever they have on their site with cybersecurity experts. Um, so that's definitely something they may not be on the current test, but there's probably questions that they're testing out to see if there'd be good ones to add.
What other questions do people have about IT, about other areas, about the test generally? Just unmute yourself and ask if you'd like, or type it in either way.
I'll just jump in and mention I don't have any specific questions. This is Jackie. Um, I I really appreciate this course because I'm about a year out from taking the test, the exam, and so I really needed, with all the simulation and work, I really needed to just sit down and hear all of the speakers think these out, really get familiar with the format, and it served as an introduction for me, not really a last step, but a first step. And I really appreciated all of it, all the time and consideration and planning. And it's been very helpful. And perhaps that's why I don't have additional questions because I'm the beginning of my journey.
Well, good luck on it.
Yeah,
But I mean, I think probably the biggest lesson that you ought to think about is doing that self-assessment. So if you're a year out, where is the best way that you can spend your time to prepare for it?
Right. Great tip. Thank you.
And I think kind of hitting on that, um, you know, 3 years ago, I was in the audience here listening to Rick and everyone else on the committee, and it was I was kind of in the middle stages of the whole process. And I think that was one of the best tips I had was the self-assessment piece. We'll be sending out a lot of information in this final email that we send out to you, and one of them is going to be a practice test. It's an older one, it's out of date, but I mean, it gives you a general idea of the types of questions you'll see, um, and the variety that you'll see, and it'll help you kind of pinpoint, as Rick said, areas that to focus on a little bit more. And I think that helped me focusing in from, trying to absorb every single topic to thinking, okay, I know enough about these areas that I just need to do some practice questions here and there, but here's where I really need to dive in and focus my efforts. So yeah, I second that. Just looking at do a self-assessment. There's different tools that ACHE has as well, where you can do an assessment of where you're at with different topics, um, to better understand as you progress forward, where to really focus a lot of your time on.
Ryan, you mentioned the HIMSS group, the professional group for IT people. Um, they have a certification. The financial management people have a certification. The quality people have a certification. Um, ACHE or FACHE is a broad across, health administration across the board, across the whole system. But you have all these focused ones, and not recommending you take it, but check them out for practice questions too.
That's a good point
So
too.
if you would like to practice more on IT, but you can't find a good source, hop on the professional association in whatever area you need.
Yeah, that's a great point. I hadn't even thought about that, but there's other professional organizations that cover a lot of the topics that,
Yeah.
we've covered here that you could probably find not only more information on, background on stuff, but also questions that they ask their candidates who are applying for their certifications as well.
One of the questions that people have sometimes is where do you find someone to be your structured interview person that you need to find someone who's currently a fellow. So I'm putting my LinkedIn profile address in there, and feel free if you haven't done it to connect with me on LinkedIn, and then that way when you get ready to apply, if you haven't done that and you need a fellow, any of us from the committee would be happy to do that.
Yes, definitely. You can always email us. I'll CC all of our email addresses on the next email. That way you have our email addresses if you want to reach out to us directly. Or as Rick said, connect with us on LinkedIn. Um, we have one committee member who isn't always able to join the Saturday, but he's agreed to provide more information if you have questions, meet with you and discuss FACHE, his journey to it. And he's also agreed to kind of help with structured interview as well. So um, Mario's not usually on this, but I typically ping him for a lot of stuff too. So if you want more time with somebody, he's always willing to lend his time as well. Let's see. What other tips do we have? Oh, one thing to bring up, we do have currently they're the previous edition, but we do have a book loaner program. Nora, who's one of our committee members that wasn't able to join us this fall, she has, I think, 2 sets of the previous versions of the ACHE bundle that she's willing to loan out to people. I think it's on a 90-day basis. She reserves it for people who have already registered for the exam, though, just to make sure that she's getting it to people who are ready to take it and may be able to benefit from looking through all those bundles. So if you don't want to purchase the bundle that's on ACHE's website, we do have some that you can borrow that are a little bit older but still contain uh, valid information and core information. So please let us know. You can email us at that CAHL advancement email, and I can get you in touch with Nora. Um, what other? Oh, there is not that you want to spend more time online, but there is ACHE is does have their virtual Board of Governors series coming up. I believe it starts on the 23rd and it lasts through mid-December. I'll send information on that, where to find it if you haven't already looked it up and registered for it. You do get additional virtual interactive credits, which, the three different tiers of credits you need. If you're a little short on those, this will fulfill that obligation as well. Plus, we'll give you a little bit deeper dive into the knowledge areas and to the exam. They take a different approach than we have to going over it, so it might be beneficial as well if you're interested. I'll send that information out. Um, Also, we do recommend, if you want to start a study group, if you want to connect with people who are here, taking this with you, more than willing to connect people who want to start a study group if that's something that might help you. I know that's happened in the past. We've had previous sessions where people form study groups that help them with preparing for the test even more. So that's definitely something we recommend. Let's see. What other tips do we have? Oh, and I did find the link for the self-assessment tool for ACHE, so I'll send that out as well. Um, any other questions about kind of the stuff that we've covered or the exam or how best to prep?
A reminder that when you pass, please take a picture of yourself holding your certificate and send it to us for our wall of fame.
Yes, definitely. And our Cal Communications team also loves spotlighting new fellows. So if you let us know that you passed, we can get you in touch with them and they'll put you in the Cal newsletter. Any other thoughts, Rick, Grace?
Um, I'm glad I'm not taking the test.
I have to recertify next year, and I thought about that. I'm like, do I want to just take the test
Uh,
again? No, no, I don't. But that's only because I recently took it.
yeah.
It was a few years ago, so I'm not ready to redo it again. But
Yeah, but feel free to reach out to us for whatever you need, and good luck to everyone.
yeah, thank you all.
Thank you. Good luck.
Thank you for all your time. Happy Saturday.